Hey, it's Erin, your ER educator, and today we're going to talk about rooming red flags. So this is part of the 2026 competencies, but this is always just a good refresher if you are an ER tech or a CNA and you happen to hear some information from a patient while you're rooming them or you see some abnormal vital signs. These are just some red flags about when you should escalate your concerns. And again, not an all-inclusive list by any means, but these are pretty common ones that you would probably see in an ER. So the first thing, we're going to just review the rooming process, look at some normal versus abnormal vital signs, and then we're going to look at red flags that could be potentially unsafe presentations that need to be escalated to the nurse or a doctor. And we're going to break those down kind of by body system. So the rooming process where we work, and again, follow your hospital's policies and procedures, but greet the patient in the lobby or the room, especially if they come by EMS. Make sure you're getting a set of vital signs. We want to get that right away because that could certainly help us escalate our care for a patient if vital signs are abnormal. You want to ask a brief story about why the patient is seeking emergency care. And I'm going to show you or talk about some buzzwords and things that we want to pick up on right away that we would maybe be like, oh my goodness, we need to escalate this and notify the nurse or the doc right away. All right, so first up, let's look at normal versus abnormal vital signs. So on the left-hand side here are your normal vital signs based on the patient's age. So you've got your neonate, infant, toddler, preschooler, school-aged, and then teen and adult. So just looking at the heart rate, the respiratory rate, and blood pressure. So that just gives you an idea. And I'm not telling you need to memorize these things by any means, but it should get flagged in the vital signs tab when you're charting these things if something is abnormal. So just keep that in mind. Where we want to kind of pay attention is on the right hand side by the red flag where it has the dangerous vital signs. So if you're rooming a patient and the patient is less than 1 month old and they have a fever of greater than 100.4, that's a red flag. If they're less than 3 months old and their respiratory rate is high, their pulse rate is high, or they have a fever, that's a red flag. Same thing with a 3-month-old to a 3-year-old. And then if you have a 3 to 8-year-old and their pulse is high, their respiratory rate is high, again, red flags. Other things that I would think about too is if their pulse is really low. I mean, we would expect a toddler or a school ager to be between 65 and 120, but if they're coming in and their pulse rate is 20 or 30, that would also be a red flag. And then again, if they're greater than 8 years old and if their heart rate is fast, their respiratory rate is fast, or if it's really low, I would also kind of be like, ooh, we need to do something about this. So just keep that in mind. Again, you don't have to memorize these by any means. Just kind of be mindful of if the patient is really high or really low and their heart rate or their respiratory rate, or like I said, if they have a fever and they're kind of under that 3-month mark, especially if they're under 1 month, that's something that needs to be escalated right away. So some rooming and red flags. Let's start with these. The first thing we're going to start with is life-saving interventions. So if you take an EMS report or you go out into the lobby and you're grabbing a patient and maybe the family runs in and they say that the patient's in the car and you hear things on the radio or you hear things from EMS or the family member and you hear things like CPR in progress or the patient is intubated or epi was given for an anaphylactic allergic reaction or the patient is unresponsive or they've had to defibrillate the patient or pace the patient, or there's uncontrolled external bleeding, like if they're using a tourniquet, or there's polytrauma. And polytrauma could be things like you've got a pregnant patient who fell off a horse, or the patient was in a motor vehicle accident and they have multiple injuries. So anything that would meet the TTA or TTA standby criteria could also be considered here. So if you hear any of these things on the radio or from EMS while you're getting a report, if there's a nurse not around, or if you go out to the lobby and they're like, hey, my family member is unresponsive in the car, maybe they've overdosed, these are things that absolutely need to be escalated immediately. Next up would be anything under airway and breathing. So again, if you're getting the story and you are listening to the patient or the family member and they're in respiratory distress, so maybe they are breathing super fast, that would be of concern. If you put them on the pulse ox and their oxygen is less than 90% on room air and it's staying down, that would be of a concern also. Or if they say, hey, I was eating some chicken and I think I swallowed a chicken bone and now I feel like I've got something stuck in my airway. Or a kid ate a quarter and they feel like it's stuck in the airway, that's a problem. Burns to the face, neck, or head, again, we would be concerned about airway, so that would be a ding, ding, ding. We have to notify somebody. If their respiratory rate is less than 8, that would be of concern. So maybe you've got an intoxicated patient or an obtunded liver patient or something that is just kind of out of it, or altered mental status and they're out of it. That would be something you'd want to be mindful of. Let's say the patient was given Narcan by the police for a potential overdose. That's something you want to escalate. If there's any sort of concerns for ingestion or overdose, whether it's intentional or accidental, that needs to be evaluated. If they're having a sustained seizure and they're not getting medications, or if maybe they are getting medications and it's still not stopping, that's a problem. We would be concerned about airway. Again, epi for anaphylaxis, or they've done a needle decompression, or they're thinking that the patient might need a chest tube if they have a pneumothorax. All things, if you heard any of those things, you'd want to be like, hey, we need to escalate. Let's look at circulation. So some of these are a repeat, but CPR in progress, if they're given atropine for if their heart rate is low, if the patient has to be paced, maybe their heart rate is low or they're in a heart block, if they've been defibrillated by EMS, if they need cardioversion, maybe they're in SVT or really fast AFib rate and they need to be cardioverted. Let's say the patient doesn't have IV access and they needed to get IV access, so they drilled an IO. If they're getting significant blood or fluid administration, that might be an indication that they're hypotensive or they're in shock, so we would want to escalate that. Any uncontrolled external bleeding, so again, if something is uncontrolled, maybe they came from home, they have a chainsaw accident, or maybe there's a tourniquet in place. Any signs of shock, which would be typically hypotension, so low blood pressure, high pulse, high respiratory rate. On the flip side, if the patient's pulse is really low, that could be a concern. If the patient has had a femur or a hip fracture and now they have low blood pressure, that could be a sign that they're bleeding internally. Acute chest pain, so if they're saying, gosh, I have the worst chest pain in my life, it just started a few hours ago, that's something that needs to be addressed versus someone that maybe has had chest pain for 2 months. Okay. Again, severe or polytrauma, and then extremity trauma with CMS compromise. So let's say the patient slipped and fell on the ice and now they're saying, oh, I can't feel my fingers or I can't move my hand. That could be a sign that they're not getting good circulation out to that extremity. So that would be something that we'd want to deal with right away also. Next up is neurological. So if again you hear or you notice that the patient is altered, so they're just not really with it, that would be something that we'd want to escalate. Signs of a stroke, so new onset confusion, lethargy, they're disoriented, they're having balance issues, changes in vision, headache, speech changes. Those would all be signs of a stroke and we'd want to potentially call a stroke code. So we want to get immediate intervention there. Maybe you have a parent that brings in a child that's completely flaccid and just kind of out of it. That would be worrisome. If you have a patient who has new onset or repeated seizures, another one, if the patient has a history of epilepsy and they're having seizures, while it's a concern, I wouldn't be as concerned as in someone who's never had a seizure before. Again, not to say that seizures aren't bad, but that's kind of how I would think about it. If you have a patient who has fall or head trauma and they're on a blood thinner, that would be something that we would need to escalate and get the patient over to CT right away. Another one would be possible meningitis, especially if we think it's bacterial. That would be an emergency. If your patient is in severe pain or distress, so if they're saying, gosh, my pain is greater than 7 out of 10 on a pain scale. And we know that pain is subjective, right? It's whatever the patient says it is. And we can kind of get a sense of that. But if they're saying, my God, this is 10 out of 10, the worst thing ever, I've tried all the things at home, I can't get my pain under control, that would be somebody that I'd be a little worried about. If they're having facial expressions or posturing that tell you that they're in pain, I'd be worried about that too, especially if they're not super vocal. If they're having changes in their vital signs that are accompanying pain, or they say things like, this just started, this is the worst headache of my life, I have this ripping, tearing pain sensation in my chest or my abdomen or my back. Those are things that would make my little ears perk up a little bit. Again, somebody who's had pain for 20 years is a very different situation than someone who comes in and is like, I was just having dinner and now I'm having this terrible ripping sensation in my chest. It's 10 out of 10. I don't feel good. That's a very different story than someone who's had pain for 20 years. When we think about endocrine or hematology or oncology patients, so your cancer patients, things that you would want to escalate would be a patient who has a really high blood sugar, although someone with really low blood sugar could certainly present in more of a neurological manner. So a patient with hypoglycemia could present unconscious, unresponsive, so we'd want to investigate that. They could also present like a stroke, so that's one of the reasons we get that blood sugar before we send them down to CT. The patients with high blood sugar, it is of a concern, but sometimes low blood sugar is more of a concern. So it kind of just depends on the patient's history. One of the biggest red flags that you might see come through triage or the lobby would be your immunocompromised patient. So a patient who is getting chemo, getting radiation, and they come in with a fever. The reason that is so bad is if they are currently in treatment, like with chemo, they have the potential to have very little, if not zero, white blood cells, which would be their body's way of fighting an infection. So if they come in and they're getting chemo and they're in between their chemo infusions and they come in and they're not feeling well and they have a fever, that is an immediate escalation. That patient has really no to little ability to fight an infection, and that patient can get septic very, very quickly. So that is a red flag. A patient that could be septic. So if they have an infection of any kind and now they're coming in and their pulse is high, their respiratory rate is high, or their blood pressure is low, that could be indicating that they are septic, especially if they have a fever and an elevated white count. An organ transplant patient. If we had an organ transplant patient walk into triage and they start rattling off a list of problems or a list of medications, I would be worried about immunocompromising as well. So that would be another one that I probably wouldn't want to leave out in the lobby too long. And then certainly a hemophilia patient with trauma or bleeding. So hemophilia happens when you don't have appropriate clotting factors. So if you have a patient who's a hemophiliac and they get trauma, and it doesn't even have to be significant trauma, but they start bleeding, they could certainly be bleeding and bleeding and bleeding, and that would be something that we would worry about. All right, next up is OBGYN and peds. So any abnormal pediatric vital signs, so go back to the beginning of the presentation. Another thing would be pregnancy with complications or trauma. Again, maybe this is your pregnant patient who falls off a horse. I mean, that right there is a TTA. Anytime that there's suspected child abuse, that would need RN or doctor escalation. If we're concerned about possible ectopic pregnancy, and that would take some digging, that would take some imaging, but if the patient is saying, you know, yes, I'm still having periods, my last period was a few weeks ago, there's a possibility I could be pregnant, I'm having severe pain, that would be something that would be a red flag, especially if their pulse rate or respiratory rate is elevated. Polytrauma, this could be in the kid or could be in the OB patient. So maybe the OB patient fell down a flight of stairs. Maybe the OB patient is dealing with some partner abuse. So those are things that would need to be elevated. A pediatric head injury, and then increased fatigue or lethargy in the pediatric population, another concern. All right, in terms of mental health, I think we're pretty well versed with these, but anytime a patient has suicidal ideation, homicidal ideation, or a potential ingestion or overdose, whether it's intentional or accidental, these would all need to be escalated, and then we need to get them into the appropriate rooms and consider sitters as well. HEENT, which is head, ears, eyes, nose, and throat. So any sort of eye trauma, chemicals to the eye, or sudden loss of vision, those could be also red flags, and those would need to be escalated. So just as to review, I know we went through a lot of different things, but I hope this is just a quick review or reminder that if you hear any of these things, these would need to get escalated. So if you're rooming a patient, any of the red flags are present, make sure to escalate them immediately just so we ensure timely emergent care. And if you want some more examples for patient presentations, you can click on the ESI handbook. This is also at the desk if you're looking for a little bit more information on how a patient could present and what that might look like. If you have any questions, let me know.